Thank you. Good afternoon to all. As ma'am said, today we are going to learn about psychosocial issues in palliative care. We all know that a lot of emotional that factors is going on there in the course of illness, but we don't have adequate time to explore that issues. If we find out that kind of issues there, so try to involve the psychologist or medical social workers in that panel, and uh, through that we'll get more exposure. Then we can able to care, we can able to give a total care to the patients and their family. So today we have Miss Muktha with us. She's a registered clinical psychologist, and she has completed her MPhil in clinical psychology from Amrita Institute of Medical Science, Kochi. Currently, she has run her own practice in on clinic in Goa by the name of Manaved, and she has a clinical psychologist, the consultant clinical psychologist at Dilasa Center for Palliative Care at Goa. So she has around 4 years of experience in palliative care. Welcome, Mukta, and over to you.
Hello, thank you so much for the warm welcome and introduction. I hope I'm audible.
Yes, you are.
Yeah, okay, yes. I'll just start my presentation and then we can begin. Yes, I hope you all can see the presentation.
Yes.
Let me start. I have kept my video off only because I have some network issues. So I'll be switching it on during the question answers and all of that. Yeah. Okay. So yeah, first of all, a very big thank you to all the participants here today for attending this and for stepping into this field, which is so close to my heart. Thank you to Pallium India for organizing this and for giving me this opportunity to interact with all of you. I also understand that you're all nurses who are new to the palliative care setting. Yes, am I right? Okay, but based on whatever introduction you have had on the basics of what is palliative care, could anyone volunteer and tell me what you know about it, about what is palliative care? Not to see how much you know, but just to know from where we need to go ahead so that I get an idea how much you all know about it. You can either unmute and tell, or you can also type in the chat box if you want. Yes, anyone? Anyone can tell me what is palliative care according to you?
So Mahima said providing holistic care.
Okay. Anybody else? Okay, all right. If we had to look at a definition, yeah. So looking at what WHO says about it, the World Health Organization says that palliative care is treatment which is aimed at improving quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, may it be physical, psychosocial, or spiritual. Right? That is what the WHO tells us. But let's move away from this definition a little bit. And instead of just theoretically understanding this, let's look at what we do on a day-to-day basis at our workplaces. Yeah. even without actively working in a palliative care setting, we are all working in hospital settings or in some kind of a medical setup, right? And we have all witnessed people suffering. So what do you see when you see your patients, when you see them sitting in the OPD, or when you look around? What is it that you see? Do you see just physical pain? Or what is the first thing that you notice about a person who's suffering from an illness? Anyone? When you see a patient, what do you see?
So Rekha said depressed.
Yeah. And spiritual pain. Okay. Okay. So the first thing that you see is that they're unhappy. Have you ever seen patients who are ill and they're happy about it? Your patients, when you see them, the first thing you see that they're unhappy, they look emotionally distressed. Some of them might be crying. Some of them might look very scared. Some of them might be restless and walking up and down. So now that we realize that the patient is not only in physical pain and distress, but there's also this component of psychological, social, and as someone has already mentioned, spiritual distress, right? And the quality of life is really, really hampered. When we say quality of life, what do we really talk about? We talk about small things, but significant things. When we say quality of life is hampered, it means they're unable to do things that they once did very efficiently, things which added value to their life, like earning for themselves and their loved ones, or being able to do things that they loved, feeling good in their mind and body. Small things like going out, spending time with their friends, enjoying their favorite dishes, playing, so much that added quality to their life is either lost or is reduced. And palliative care is all about looking into these aspects along with pain and symptom management, right? So we talk about holistic whole person care. We talk about psychological well-being, spiritual well-being, emotional well-being, social well-being. And apart from the fact that illness affects well-being in all these areas, we should also not forget that we have a mind-body connection and that it's a two-way connection, right? So just the way the body affects the mind, our mind also affects the body. So for example, when a person is in emotional distress, it often exacerbates or increases their perception of pain. Yeah. So psychological, social, and spiritual well-being will also have an impact on the person's physical well-being. And that is why we need to look at all these different types of well-being. Again, caring is not only limited to the patient in palliative care settings, right? We are also caring for the caregivers, for the families. Why is that? Why is family the unit of care? What do you think? Anybody? Anybody wants to make a guess about why we care about the entire family? Yes, they are the caregivers of the patient, definitely. But again, even when we say that they are caregivers of the patient, in other health settings where there is not, when we don't speak about palliative care, but any other healthcare setting, we don't really actively care for the caregivers, right? But in palliative care setting, it becomes very, very important because yes, as Mahima ma'am has said here, family is also the sufferer in the treatment. Basically, the patient's symptoms and the family's coping with the illness are not unrelated. Okay, so let's say, for example, if I have a 37-year-old patient, okay, a 37-year-old woman who has been diagnosed with a life-threatening disease, is it traumatic for her? Yes, it will be definitely traumatic. will it also be equally traumatic for her husband, let's say 40 years old? Yes. What about her, let's say her 10-year-old child or a 12-year-old child? Would they also feel that it's traumatic? And what about her aging mother? Right? So, as I see all these yeses coming in the chat, we see that a person's diagnosis is not only limited to that person or that patient, it is affecting the entire family. It's a family trauma, it's a collective crisis, not an individual crisis. The emotional and physical resources of the entire family are threatened, right? When we say emotional and physical resources, right from money to savings to resilience, ability to deal with stress, so many things get affected and threatened for the entire family. Because the patient is not isolated, they are a part of a family system. And their psychosocial physical health is going to impact the family and vice versa. So you might have seen patients with terminal illnesses who have spouses suffering from depression or some other psychosomatic symptoms, where their health also deteriorates because, as someone said in the chat, they are also equally suffering. The losses which are suffered by the patient are also losses suffered by the family. For example, a patient's loss of role as the head of the family is also the family's loss of a primary breadwinner. And on top of that, we definitely have the added exhaustion, the stress which comes with caregiver duties, which often leads to burnout, compassion fatigue, guilt. And a part of our role is to help them vent out and to give them some relief from this so that they don't edge towards a burnout. Apart from this, due to the inadequate understanding about what palliative care is, sometimes even a referral to a palliative care service is experienced as a crisis. When people don't really understand what it means to take a person to or to take a patient to a palliative care hospital. For example, we have had patients at the LASA, the center where I work, who were brought there by their daughters or by their sons. And then these daughters and sons were blamed by the entire family, by relatives who were really angry at them, who kept saying that. Hello? Yeah. So who kept saying things like you are giving up on that patient, you are leaving them there to die, or you're not fulfilling your duties, you're being cruel, you're neglecting the patient. So many different things which come out of a misunderstanding or a lack of awareness about what palliative care is. So that added stress is also there for the caregivers, and that is why we need to look after the entire family. So family-centered care, where healthcare team, the patients and their families have an equal partnership, is the basis of the work that we would be doing. All right, now you might agree with me on all of this. You might say that, yes, it's not only physical illness, that there are other psychosocial issues, that it's the entire family which is facing these issues. But some of you might have a question about why you need to know about it. I'm not a psychologist, I'm not a social worker or a psychiatrist. What will I do about this? But you need to know about this because you need to do what you can do in this particular scenario. Because it's a multidisciplinary team, we all need to be aware of the possible issues which can arise so that we identify, we assess, and we do our bit to support. And if needed, refer to a specialist. There is a psychosocial dimension to the work of all the professionals who are involved in palliative care. And understanding this will definitely strengthen the practice of any professional who is working in this field, maybe a doctor or a nurse or a social worker or anybody else. And considering that you're nurses, you have a very unique role to play in psychosocial support. You are the ones that the patient and family are most in contact with, on a daily and often long-term basis. So being a constant companion, you are in a position to build a trusting relation with them very naturally. So you are the ones that they talk to. You are the ones that they tell their concerns to, tell their stories to. So even if you can't actively do anything to help relieve the emotional suffering, you can always listen to these stories. And it's always important that we never underestimate the therapeutic value of listening empathetically to the story. When I say listen, I don't just mean randomly listen like we listen to what our friends are saying. It is, how to listen, to be actively engaged in the listening, to be empathetic is something that I think might be covered separately in your communications session. But yes, never underestimate what you can offer your patient. So you need not be able to hand over solutions to them, but just being able to give them a space where they are heard is going to be incredibly healing. Now, when I say healing, I don't mean a cure. Yeah, you might feel puzzled that how are these patients going to heal? But this is one thing I'd like to clarify. When I say healing, when I say curing, it's about getting rid of an illness. Yeah. But healing, on the other hand, is accepting that there is an illness, that there is going to be change which comes with that illness, and to start looking at themselves in a different light, to not look at themselves as sufferers, but on the other hand, to start seeking their own resources to facilitate this change and this acceptance, and looking inside and finding the strength to deal with this entire journey. That is what I mean by healing, and you can promote it in a big way. So let's first look at what psychosocial spiritual issues can arise in this context so that you'll be able to identify them when they happen, when they occur in your patients. Along with that, let's also look at what can be done to assess the extent of distress and to treat it. Now, it is not really possible to separate out these issues into psychological, social, and spiritual because they are pretty much overlapping. Yeah, we can only do it up to an extent. So when we are discussing a particular issue, it will definitely have psychological aspects, along with it also social aspects and spiritual aspects in varying degrees. Yes. So the first thing, one of the first issues that comes up in palliative care setting, communication issue.
Ma'am, you can continue.
Communication issues, yeah, and breaking the bad news. Yes, I won't go into the details of it because I think breaking the bad news will be already covered in your communication session. So instead of getting into the protocol of how to break bad news, I would like to draw your attention to what happens when there is miscommunication about the illness and miscommunication within the family also. When we are doing this hurriedly, when we are not communicating things properly to the patient and to the family, it can cause further problems like arguing, non-compliance with treatment. If people have misconceptions about the diagnosis and treatment, they might not be happy with what you're doing if they're not properly told what to expect from the treatment. So supporting and educating the family is vital. It's important that they have an adequate understanding of the illness in the first place and the expected process. So we need to give enough time to address everyone's concerns about it and to help them communicate clearly with each other. Because collusion is again something that is very commonly seen where things are hidden from the family members itself, often from the patient. So the patient is not told the diagnosis or the prognosis by the family members. So even the most functional families find it difficult to talk openly about this in palliative care settings. They naturally tend to hide feelings, mainly to protect other family members from feeling hurt. So they might either hide their distress from each other or they might hide the news only in the first place, especially from children. Before I began practicing during my training, a major part of my work, major chunk was with pediatric cancer patients. And I've seen innumerable parents who constantly hid their own pain and sadness and fear from their child. Why did they do this? Because they felt that they needed to stay strong for their child. But the issue is, children sense hidden restlessness and anxiety. They know that their parents are hiding something from them, and that is more unsettling and scary. Yeah. So we need to communicate properly, and we need to help the family to communicate properly with each other. So usually when it comes to children, there is no choice about whether or not to tell them. Because one, even if you don't tell them verbally, they read emotions around them. So they notice that adults are talking in hushed voices, or they are quickly wiping their tears. They also respond to body language. They can see sympathy in people's eyes. And thirdly, they are aware of changes in their routine. So they realize that their mama is in hospital and she is not dropping me to school anymore, or my auntie is packing my tiffin, and nobody is telling me when mama is going to come back. So these are things which leave them hanging, not knowing what's to happen. So honest communication, open communication, in a way that children understand, is the key in this case. And we need to encourage that. We also need to help parents see if they're misguided in their attempts to protect their children from harm. So one of our major roles is in facilitating open communication and expression between members and between the families and the treating teams. The second issue that we come across is predominantly social in nature, and that is loss. When I say loss, I don't just mean loss of life. There are so many other losses that are experienced by patients during the course of the illness in relation to their social world. Yes, mainly because their engagement with the social world, with the world outside home, and with the roles and relationships in the family undergo a drastic change with the illness. So there are so many different losses. There is a loss of future, there is a loss of role or identity, there is a loss of self-esteem, a loss of social engagements outside of home. For example, if I'm a teacher and I am diagnosed with a terminal illness and I have to stop working, then definitely there is a loss of my role as a teacher, but it is also associated with so many other losses. There is a loss of financial independence. There is a loss of a meaningful contribution to society. There is a loss of my confidence. So many things. So much of our self-concept is linked to who we are and what we do in a social context. So this is a major psychosocial issue. And as mobility and energies decline, it becomes harder for patients to participate in social events and to maintain friendships which were built on shared activities and interests. And social isolation becomes a frequent source of social pain for both the patient and the carer. In some cases, it is possible to an extent to get them to meet friends, to get them to meet colleagues, to have meaningful interactions with them. They can either call them up or they can meet them sometime. But for some others, the change in the way they feel about themselves and their declining function creates a big gap between their past social engagement and their present condition and the limitations it brings. So for them, a solution may be to participate in new social groups altogether instead of trying to integrate them back into older groups. What do I mean by this? When I say new groups, I mean most of the times you might have heard of cancer support groups where patients and the families can share their own experiences, where they can both learn how others deal with a changed identity and compare their own situation. And they can also continue to feel that they can make a contribution to the society even when they're ill. Especially with patients who say that they have stopped talking to people because they hate the look of sympathy in their eyes or pity in their eyes. They notice that people hesitate in sharing good news, that they don't talk about anything else but treatment. So such kinds of experiences can lead to a feeling of being left out or being unable to connect with those who are not affected by the illness and going about their own previous routines. This can also lead the person to withdraw further, and it can cause them more pain. Along with the patient, carers will also have changed identities. So they also might be struggling to sustain other commitments, commitment to a job or to some other needy family member, or life may be just put on hold because they put the needs of the dying person first on the priority list. But as we all know, man is a social animal and we need connection. So you might have witnessed caregivers helping each other in hospitals, striking up a friendship in wards. They do so naturally because of their need to connect socially and because they feel understood, they feel a sense of connection. And so support groups can really help when it comes to social pain or loss of social identity and social engagement. So you can definitely think of starting up support groups. You can take help from students, from volunteers, and definitely do something to improve social engagement for your patients and their family members. Thirdly, we move on to unfinished business. Unfinished business is, okay, can anyone make a guess about what this is? What is unfinished business? What could it be? When you think of a person who's dying and you say something like unfinished business, what could it be? Will papers, okay. Anything else? Legal issues, yes, definitely that is a part of unfinished business, but there is also something more. Children getting married, yes. Sorting out relationships, absolutely, absolutely. Uh, it could be anything. It could be about dreams, ambitions, plans for life, uh, building their own house, taking care of financial commitments, repaying loans. And this kind of unfinished business can lead to considerable distress and it can manifest in many different ways. It can come out as restlessness or anxiety or guilt, discomfort, helplessness. How to identify this? You just have to keep your ears open and notice. If you hear for patients' regrets, you would most likely get to know about their unfinished business. For example, you hear a patient saying, I wish I had not stopped talking to my sister. Now, looking back, it seems like such a small matter when faced with the possibility that I'll never be able to talk to her again. What does this tell you? That reconciliation, maybe asking for forgiveness, is an unfinished business. And being able to complete that would bring some peace to that patient, right? So mostly unfinished business would be a major concern in younger patients in their prime, who have children who are small, children who are still studying, children who are not settled, or who have parents who are aging. So here, the unfinished business would be revolving around their responsibilities. The patient's responsibilities as a parent towards their children and as grown children towards their parents. Now, in this context, the most common emotional distress would come from the feelings of guilt of not being there for them and anxiety about how the children will cope on their own. So, let me just give you an example here of a very strong patient whom we lost a few months back. And I think this example will help illustrate all the 3 points that we have discussed so far: communication, loss, and unfinished business. It will also help you see what I mean when I say that these factors are all overlapping. They cannot be independent of each other. So with this patient who was a lady in her 30s, diagnosed with an illness, only to know that it was in the terminal stage, that there was no curative treatment available at that point. So definitely it came as a shock. It was sudden news. and she had to stop her work. She was an IT professional. So she was faced with loss of identity as a young professional. As days passed, she quickly deteriorated, becoming dependent on others for her basic needs. So she could not bathe herself. She needed help to walk to the toilet. So there was also loss of dignity, which was especially painful for her to bear at such a young age, when no one is really prepared mentally for something like this. There was a loss of role. She had two young children, one barely a toddler who could, just couldn't even walk yet properly. So she couldn't fulfill her role as a mother. Her family was extremely supportive. They reassured her that they would take care of her children. So there was no anxiety regarding that per se, but there was the pain of leaving them behind, not being there to see them growing up. It was something she was leaving unfinished. And sadly enough, there was not much that could be done to help her complete the task, so to say. Unlike other unfinished tasks like reconciliation, which we saw in the first example, which is just a phone call away, this particular patient, it was very difficult to help her complete these unfinished tasks. So what happened was with her was what she did, she asked her child to be brought to the hospital. Her elder child, a girl extremely attached to her, 12 years old, what she did was, once the child came to meet her, she sat with her and told her how ill she was. She explained to her what a terminal illness means, what stage her illness was at, and she cried with her child and told her that she loved her and that she'll always love her. As a palliative care professional, when she told me this, my first thought was that was such a beautiful, difficult, and brave thing to do. Telling your child that you're going to go. But that was not how her family felt. When she was telling her daughter this, her family had tried to stop her, constantly saying that she shouldn't be saying things like this, questioning why she was troubling the child, why she was putting her child through this, etc., etc. And that really disturbed her. So she had asked to meet me just to, because she had this question of whether she was being a bad parent by doing this. But somewhere she knew the answer herself. What she told me was, I know they didn't want me to say it, but it's the truth. I very strongly needed to say it. And the reason why she decided to tell was, one, she didn't want it to come as a shock for her child. She wanted her child to be prepared for what was to come because it was inevitable what was going to happen. And secondly, she said, if I hadn't told then, I don't know if I would have gotten the chance to tell her that I loved her and that I wasn't abandoning her. Here comes the issue of communication. The family was trying to protect the child. They didn't want her to know that the mother was going to go. But as research with children of deceased parents shows us, it is best for the child to be involved in and given a choice to say goodbye. The ideal step to follow for us would have been to find out from the child what she already knew by picking up on cues from the atmosphere. Secondly, to help her mother communicate with her, if necessary, reassuring her that this was good parenting, to give her child knowledge of what was happening. And thirdly, helping her identify sources of support for the child. And she intuitively did all of that, right? She asked the child to be brought. She spoke with her, communicated with her clearly. And thirdly, what she did, her only request to us had been to help her child through the process of understanding the loss and supporting the child through it after she was gone. That was the only help she had asked us for. And in doing what she did, telling the child and making the request to us, she did indeed take care of her unfinished business to the best of her ability in that given situation. And when we validated her decision to communicate with her child, and we assured that we would talk to her, she could give us a genuine smile even in that condition. And that was the last we saw of her. Now, many a times, families are not ready to have this conversation. They would rather protect children. But what they don't realize is by keeping them ignorant, we are doing just the opposite of protecting them. We are making them more vulnerable. We are not opening up doors for them to ask their doubts, to prepare themselves for what is to come, and to ensure that they don't blame themselves, which children often do. Yes. So moving on, so far we saw communication, we saw loss, we saw unfinished business. Next comes a very practical issue, that is financial problems. When we look into a comprehensive psychosocial assessment, we also inquire about financial concerns. Many a times when people undergo long treatments over years without any money coming in, it drains out much of their savings. Some of them might be from a poor financial background to begin with. So financial issues is a very real concern in palliative care settings. Why are we addressing it under psychosocial issues? Because it is a source of distress for many. It can even stop them from help seeking. There might be fear and anxiety about it, which again means they might not respond very well to a treatment if these underlying causes of anxiety are not addressed. So talk about it. Talk to your patients about any financial troubles that they are facing. For some who have been well off until then, receiving charity or asking for help can be extremely difficult because their self-esteem gets affected by it. So what is our role in all of this? As nurses, what can you do? You can talk it out with them, listen to their perceptions, how they feel about taking financial help. Is there something that stops them? And secondly, get them in touch with agencies that can provide aid. For example, at Dilasa, we have the society aid which is available. So the decision makers are informed about it right at the admission itself. They have to fill a form. And again, here, if you're doing something like this, if you're providing them some financial aid through your hospital or through some other charitable societies, it is important that all those involved in the treatment know about this. For example, we had a patient who got admitted, and the day he got admitted, he started insisting that he wants to be taken home. Very adamant about it. He had a young son who was fresh out of college and who had started working. Now, the nurses inquired with him, was he not happy with the care he was receiving? Was his pain not being managed the way he expected? Basically, they tried to find out what was the reason he so desperately wanted to leave. But then we realized that he was troubled, thinking that this is a private hospital and it's going to cost a lot and we can't afford it. Being a proud man, he felt ashamed to share this with the treating team directly. But he told his wife, and she told her son. Now, what the son did was, he just kept reassuring the father again and again, saying, you don't think about it, I'll manage. You don't think about it, I'll take care of it. Now, this the patient felt was just false reassurance. He was like, this is a young kid, he has just started working, what is he going to do? So this patient needed to be involved in the process of financial decision making. Once he was told about the aid and how it worked, he was much more relaxed. He was much more cooperative in the treatment that was being given. So ensure that you involve the patient as much as possible in this financial decision making process. And not just in terms of finances, but otherwise as well, because it maintains their sense of autonomy in their lives, the sense of control. Right? So that is about financial problems. Next comes spiritual issues. Some of these being socio-spiritual issues as well with an overlap. Spiritual well-being is one of the most important influences on quality of life at the end of life. Patients may experience a number of spiritual issues, uh, including a lot of things like lack of meaning, guilt, shame, hopelessness, loss of dignity, loneliness. They might have anger towards God or feeling abandoned by God, feeling out of control, grief, spiritual suffering. This is not only limited to religiosity or faith, it goes beyond that, because as one nears end of life, or as one faces the reality of being mortal so closely, they might begin to have existential questions like, what is the meaning of life? What is the purpose of life? And with that, they might start to think about the past and question about what did they contribute to this world? What am I leaving behind? So it is important to help them reminisce and to look at their past trumps, what they achieved. It could be as simple as raising three good children of good character, even through difficult circumstances, or being a valued employee of the company that they worked in. Anything that they have achieved, knowing what they did was valued is what will keep their hopelessness at bay. So this is a time when reviewing the past can put the present in context. It can be very affirming to the dying person, and it can be done in several ways. So for some people, informally talking with family and friends can very well give them the opportunity to go over past traumas and tragedies and to receive confirmation from their friends and family that their contribution has been valued, that their life is valued. And for others, a more formal life review may be helpful in settling anxiety and uncertainty. Formal life reviews are processes which have been developed by psychologists in many parts of the world. Many of these are also available online for free, so those can be used. Uh, we also, so when I say informal reminiscence, we had this patient who would constantly complain and crib about things. She was never satisfied, never content with the way things were going. And she would constantly complain about her pain, in spite of giving her medicines. Okay. So it was not like her pain was not being treated. But in spite of that, she would still keep complaining. And instead of her usual caregiver, in between, we had her grandson who came and visited for 2 days. And we asked him to, do this reminiscence with her. And he started asking her about past incidences when she was young, when she was his age, how did she meet her husband, etc. And she didn't once complain of pain in those entire 2 days. So, definitely, again, research also shows that this kind of a life review leads to an improvement in life satisfaction and reduced stress. Associated with a life review can also be a wish to leave behind a legacy or be involved in planning for the future of loved ones. So, some might want to have concrete gifts that they leave behind. For example, a painting that they made, or a poem that they wrote, or a sari, a recipe book. A parent with young children who is dying may wish to leave a letter, or an audio tape or a videotape for the children to keep and to go back to as they grow up. And you can help them make these memory books with messages, pictures, other small souvenirs, or something personal for all the things that they would miss, like their child's 21st birthday or their marriage, graduation, their first job. So basically any kind of material which focuses on demonstrating the value of the child for that parent or the patient, and reminders of times which they have shared. And this is likely to be greatly treasured, because you can also imagine that somebody you love, whom you have lost, what if they had left a letter for you, or what if they had left something of their own as a gift to you? So definitely it would be greatly treasured. So making a will is also another way of ensuring that your wishes continue to carry weight after your death. Also another way of taking care of unfinished business that somebody had also pointed out in the chat. Sometimes, many a times rather, patients are pretty hesitant when it comes to making a will, but it's always important that we encourage them to do so in palliative care settings. Apart from this, spirituality, very simply put, is being connected to something greater than your own self or higher power, not necessarily God, not limited to religion, but something higher, a higher power. So, assessing a patient's spiritual beliefs, assessing the importance of spirituality in their life, exploring whether they belong to a spiritual community is something that we need to do. Yes, don't assume, it's always better to assess. A simple question is often sufficient. You can just ask them, is your faith or your spirituality helpful to you? Or how important would you say it is to you? And further, you can also ask, are there ways in which we can support you in your faith or spirituality? Or can we help provide you with anything or any facilities to support you in your faith? Uh, these are small things which can be done actually. For example, you can just give them a rosary. You can just help them. So we had this patient again who reported that he used to visit a local temple every day evening. And that was a part of the social fabric of his life, where he also got to meet his neighbors and they would sit and talk and then pray and then come back. So when we inquired if he had noticed when he was brought in that we had a small place of worship in the hospital, he said yes, but he said, I'm bedridden. We asked if he being able to go see the idol in the evening and just sit and pray there for some time would help in any way. He said yes. It was just a matter of arranging for a wheelchair to take him to the next room. That's it. It had never occurred to him that he could ask for it and that the hospital staff would be willing to do something about it, because that is not how the hospitals work in his mind. For him, the hospital staff was there to take care of his physical problems, not his spiritual issues. So make sure you are asking from your end. And again, as you say, as you see, it was just a matter of a wheelchair. Interventions need not be complicated. They need not be about super brain science. Mostly, they just need to be human and compassionate for them to work. How does this help? How does it help that we support them in their faith? For those people who believe in it, concepts like transcendence, soul, liberation, reincarnation can help them deal with dying, can help them make meaning out of it. It can also help reduce suffering. It can facilitate acceptance of the situation. So these acts, all of these can act like a buffer against distress, particularly hopelessness, helplessness, loneliness, depression, death anxiety. Transcendence, that is a belief in a higher power beyond human existence, also enables connectedness. It removes the isolation of suffering by setting it within a larger landscape. And the religious traditions of the world, regardless of where you are in the world, have their own interpretations of suffering. Many also have practices which enable people to transcend their suffering and their pain, and to facilitate acceptance through prayer, through meditation, through different rituals. And even for the family, rituals following death is how the family makes sense of their loss. So because if you notice, all these rituals, post-death rituals, are acts of remembrance and they can aid in processing grief. But make sure that you're not letting your own beliefs interfere, that you're not pushing the patient in any way to engage or to not engage in spiritual practice. It is our job to respect the patient's spiritual orientation or lack of it, and to encourage spiritual practice if that person is already engaging in it, or if they would like to engage in it, but not to push those who do not. Yes, you just need to ensure that patients get the opportunity to express their spiritual beliefs and practices. Next comes grief and bereavement. Grief, as we all know, is the emotional response associated with loss. Inevitable, right? But again, it is an adaptive adjustment process. Many a times, it can be approached with courage if proper support is available. Intervention is not always warranted. For the majority of people, although bereavement is painful, their personal resilience will ensure that they are adapting normally to the change. So we cannot justify a routine intervention because normal grief is not pathological. But as the patient and family journeys through palliative care, we see that the clinical phases of grief progress from anticipatory grief through the immediate news of the death to stages of acute grief, and for some, a complicated bereavement period. So, first of all, what are the features of normal grief? We need to know this so that we don't pathologize any and every grief. Normal grief is when you see emotional waves of distress, people crying unavoidably, they're preoccupied with thoughts about the deceased, there is reduced concentration, they might have other somatic symptoms like restlessness, numbness, weight loss, fatigue. They might have behavioral symptoms like social withdrawal. Here we just need to be a supportive presence. You just need to let them know that you are available to help if they feel the need for it. But sometimes active intervention is required when we see some abnormal patterns. And what are these abnormal patterns? There might be anticipatory grief, which precedes the death, which happens before the death, just from the expectation that the death is going to come sometime. Yes, there might be common difficulties which come with anticipatory grief, such as impaired coping, where family members might deny the seriousness, they might withdraw, they might not be involved in the treatment process, they might show anger towards the treating team. Our role is to encourage them to express their feelings openly and help them recognize that saying goodbye is a process with opportunities to celebrate the life of the patient, to express gratitude, to take care of unfinished business, and reminisce on the way before you say goodbye. Complicated grief, on the other hand, represents a pathological outcome, a clear-cut pathological outcome involving psychological, social, or physical morbidity. So it can either be prolonged grief many a times, but even after 6 months, if you see that the person is having difficulty accepting the loss or meaninglessness, uh, that is what you would call complicated grief, and mostly associated with poorer physical and mental health outcomes and increased suicidality. This is when active intervention is required. Inhibited or delayed grief is also another avoided form of complicated grief, where there is, after the death, there is a phase of normalcy, and then suddenly, out of the blue, the grief hits the person. Complicated grief is more likely in untimely, sudden, traumatic deaths, when there is a lack of support systems in place, when there are previous vulnerabilities, and in case it was a dependent relationship between the patient and the caregiver. Apart from that, we also have what we call disenfranchised grief, which we call the hidden sorrow, basically of marginalized people for whom there is less social permission to express their loss or grief. For example, homosexual partners or extramarital relationships, where there is lack of societal acceptance. That is what we call disenfranchised grief. Lastly, we have psychological issues. So we spoke about social issues, we spoke about spiritual issues. Moving on to psychological issues, we definitely know about the common ones. We know about anxiety, depression, body image issues, including loss of attractiveness, especially in cancer patients. But we can put it all together under the umbrella term of distress. Yes, that is an unpleasant emotional experience which is tied to and interferes with the ability to effectively cope with illness and illness related treatment. Now, making of a psychiatric diagnosis and rapidly identifying of patients who need help is pretty difficult for many reasons in palliative care. One problem is that psychiatric symptomatology may be mimicked by the side effects of medications or the disease process itself. So here, the difficulty in diagnosis is most of the times due to somatic symptoms. So underdiagnosis and under-identification of psychiatric disorders because the professionals could not recognize it is very highly prevalent. So being able to identify and assess is very important for all of us. And for that, we have this very simple table here which can be used, which you can go back and refer to. It will be shared with you, which will help you identify and rule out other considerations when it comes to depression, anxiety, and adjustment disorders in palliative care. Now, in a drive to address this misassessment and misidentification, especially in the context of cancer care, the National Comprehensive Cancer Network in UK, the NCCN, has promoted developing brief rapid screening tools for distress, which any of you can administer very easily. Yes, and one of them is a very common one is the distress thermometer, which is very, very helpful. Depression is the one which frequently remains unrecognized and untreated because it is dismissed as normal reaction, even in the face of severe affective disturbance. The most common diagnostic difficulty, as I said, is the somatic symptoms that patients present with in the context of a possible depression. And the challenge is to determine whether these symptoms are part of the depression syndrome or a direct biological result of advancing illness, especially cancer. So focus more on non-somatic symptoms, especially classifying ones. For example, inability to access past good memories is something which you will see in clinical depression, or a change in self-image will also be seen in when it is depression. On the other hand, if it is just normal grief, self-image won't change. They will readily respond to comfort or care, and they will be able to enjoy pleasurable activities, which won't happen if it is depression, clinical level depression. So it is always better to be on the safe side, to be suspicious and refer to a specialist. Again, occasional thoughts of suicide are quite common, but if they become frequent, persistently present, then they can indicate the presence of a psychiatric complication. Many a times when we are assessing risk and intent, we just need to acknowledge their need for control over death, and that is enough for many patients. Nursing staff have an important role in identifying patients who may have psychiatric symptoms because, as I said earlier also, nurses spend more time in direct patient contact, which enables them to observe behavior more closely. And the nature of intimate nursing tasks may also give an opportunity for patients to express any psychological distress. So you might not be able to identify specific disorders, but you're definitely skillful in recognizing significant psychological distress when you see it. How can you establish that a patient is depressed and requires treatment or further assessment in a palliative care unit? Most important is assess. Use preliminary screening tools like the phase scales or the distress thermometers. You can also use clinician rating scales, standardized rating scales, which clinicians use like the caregiver burnout scale, the BDI, that is like depression inventory. You just need to gauge the emotional temperature of that person, right? Now, in case of palliative care, many a times, patients might be unwilling to or unable to discuss symptoms. But research shows that asking caregivers instead of patients is extremely unreliable. So please don't do that, because their ratings are closer to their own distress rather than the patient's. Again, when I say use screening tools, use rating scales, not all of them can be used because not all are valid in palliative care settings. Research suggests that Edinburgh Depression Scale is quite useful. So is the Wet Depression Inventory and the Zoom Self-Rating Depression Scale. Now, apart from all of these scales and these ratings and screening tools, funnily enough, just asking the patient, are you depressed, is one of the most reliable predictors of depression. Sounds really unreal, but it's true. So it is always helpful to assess at admission for any kind of psychological issue. But always keep an eye out for appearance of new symptoms, just like you would do for any other physical symptom. So all members of the healthcare team can observe, can subjectively report distress that they feel is psychological in nature or is psychologically mediated, like pain or breathlessness. It might or might not meet the criteria of a discrete psychological disorder, but regardless of the etiology or the diagnostic label, it is ultimately about the patient's subjective distress, and we need to help them with that. Our work is also not only to identify problems, but also to see and help the patients see their current support systems and their strengths, which can help with the distress and their coping strategies, which are their strengths. Apart from that, what your patients need from you in terms of psychosocial skills, regardless of what the diagnosis is, it includes the need for understanding of symptoms, the nature of disease, the prognosis, the process. Secondly, they need acceptance from you, regardless of how their mood is, whether they're being sociable, what is their appearance like. There is also a need for self-esteem. They need to be involved in decision making. A need for safety, feeling secure in the facility. Belongingness, a wish to feel needed, to not feel like a burden. Love, expressions of affection and human touch. Spirituality, as we've already discussed, an explanation of meaning and purpose. And lastly, hope for an improvement in any aspect of their life or of their living till the day that they are alive. So, in the provision of psychosocial care for people at the end of life, each of these needs must be identified and addressed. These are some final do's and don'ts for you. Make sure that you're being honest, trustworthy with the patient, you're respecting people's right to make their own decisions, that you're keeping aside your own biases. You're making it clear to the affected person that even if they refuse help now, they can still access help in the future, that you're ensuring confidentiality unless the issues affect the safety of the individual or other individuals, and that you provide them with adequate information and communicate clearly with them. And please don't make false promises, give false information or false hope. Although telling their stories does help them, don't pressurize them into telling you their stories. Don't judge the person based on their actions or feelings. Don't talk about your personal issues or troubles with them. Don't compare your issues with them and tell them. Don't philosophize or preach or impose your own perspectives on them. As you see, most of these needs and most of these do's and don'ts are not about you being able to provide technical therapeutic expertise. It's more about being a non-judgmental, compassionate presence who is witness to their suffering, who is giving them space to express their distress, and who's accompanying them on their journey, who is trying to help add life to their days, not simply days to their life. Thank you. Yes, any doubts about all of this? It's quite a vast topic, and I have tried to cover as much as I could, but You might have doubts, so please feel free to ask.
Okay, thank you. Thank you, Muktha, for the wonderful presentation. Anybody have any doubts, please ask her. Anybody? So, Mukta, they don't have any doubts. So we can move on to the case presentation. Before moving on to the presentation, I would like to highlight few things. From the day beginning itself, we have learned about palliative care is a total care. So if you need to give total care, we need to do the proper assessment. So if you do the proper assessment, we can able to improve the quality of life of the patient and their family. So and also we understand that palliative care is not for the patients, it's for family also. So family is also suffering a lot along during the patient's illness. So they need a, proper attention. Patient and as well as the family need a good care. And also we need to find out their psychosocial issues. If there is a psychosocial issues there, definitely their physical distress will be increased. So when a patient comes to you with a physical distress, so we are the person to take care of the physical problems. And also when you take care of that physical things, so you have to try to talk with the interact with the patients and family, then you can get some idea about their psychosocial issues. Because if they have any psychosocial issues there, you will get some clues. So then you can talk to your that entire team. See if there is a psychosocial workers there or clinical psychologist there, you can talk to them and try to include in that involve them in that patient care. So that person could explore more psychosocial issues so that we can able to give total care to the patients. So that is how we can cover the four aspects of cover the care. And also we can, if you cover that four aspects, definitely we can able to improve the quality of life of the patient and their family. So we can move on to the patient story. This today case presented by Sister Vaishnavi. So to you.
Good evening, everyone. I am Vaishnavi, staff nurse in Harborpur Christian Hospital. Today, I am going to present my case presentation. My patient details are age 85-year-old, gender male, diagnosis multiple pressure ulcer, chronic bedridden state, and old CVA. I am presenting complaint was pain in bedside side, anoxia, pyrexia, drowsiness, bedridden, and constipation. History of illness was he had history of diabetic mellitus since 20 years, had history of CVA since 15 years. He had bed sore since 2 years, stage 3rd. Examination was in physical examination, bone and muscles can be seen. GCS was 13/15, temperature 101 degree Fahrenheit, pulse rate 104 beat per minute, respiration 22 beat per minute, SpO2 95%, PP 110/70 mmHg, GRBS 210 mg per dl, and fetal adenomatous. Treatment and significant investigation. Patient surgery were done in debridement of sacral and bilateral trochanteric ulcer, and investigation was serum creatinine 1 mg per dl, electrolyte sodium 129.5, potassium 3.50, and chloride 92.7. CBC in CBC WBC was 22,900 per ml, HB 11.2 gram per DL, and platelet 3.17 lakh. And HbSAg, SCB, and HIV was negative. In pus culture, heavy pseudomonas, ergonosis was present. Psychosocial aspect. 85-year-old married man living with his wife and two sons and two daughter-in-law, jobless, bedridden, son were doing jobs in private sector. No one used to come to visit him. He was facing financial crisis, sleep disturbance. He was anxious regarding his condition. During visiting hours, only his grandchildren were used to come. And medication was uh, tab levofloxacin 750 mg OD, tab panto 40 mg OD, injection PCM 900 mg TID, injection augmentin 1.2 gram TID, injection tramadol 100 mg TID, injection NSAID 8 mg TID, syrup clemifene 10 ml BD, syrup tab metformin 500 mg BD, tab glimepiride 1 mg AMOD, and dressing with esol and NS TID. You get dressing TID and you get change every 2 weeks. And main concern was pain, discomfort, loss of appetite, emotional unstable, sleep disturbance, less intake and output, diabetic diet, foul smell from ulcer side. Summary. A bedridden patient following a CBA and was admitted for management of infected pressure ulcer. He was nursed on air mattress with 2-hour positional change. He was on antibiotic and analgesic. Oral intake was inadequate. So he was on NG feed, high protein diet, on high calcium diet. Debridement was done. He was started on physiotherapy, and the time of discharge ulcer looked healthy. Discussion point. Do we need to provide palliative care for this patient? What were the problem he was facing? Was his family supportive?
Okay.
Thank you.
Thank you, Vaishnavi, for the presentation. If anybody need any more clarification regarding this patient story, please ask her. Otherwise, we can move on to the discussion points. Anybody need any more clarification? Okay, we can move on to the discussion points. The first question is, do we need to provide palliative care for these patients? So what is your answers? So we would like to expect the answers from the participant side. Yes. Definitely, this patient needs palliative care. You need to give palliative care for these patients too. So I understand that there are a lot of physical distress, physical issues were there. Apart from that, there are some psychosocial issues also. He has 2 sons and 2 daughters. Nobody's willing to take care of this patient. So he is alone. He's staying his wife. So he is a bedbound patient. So he has a lot of psychosocial issues. Today we will discussed about the psychosocial issues. So Muktha, over to you.
Yes, ma'am. So anybody else would like to contribute anything in terms of the family support or the anxiety that the patient was facing based on all that we have discussed today in the session? Anything that you can think of? Okay, fine. So one thing we definitely know that the patient was having some anxiety and there were financial crisis, there was sleep disturbance, and that his family was not really visiting. Yes, as Mahima ma'am is saying, social issue, nobody visits him. So that is something that we can definitely look into. We can find out why that is happening, and if there is something that we can do to change it, to help the family also understand that this is important, that they visiting him is also important to keep up his morale, and that can affect his disease trajectory also. Yes, so that is something that is where we can, talk to the family and we can find out what is happening. Apart from that, when it comes to the anxiety, so it could be again due to multiple reasons, and we need to find out the reason behind the anxiety. It could be about the future, as in he might know already what is happening and that is why he is scared. Or it could also be because of uncertainty. He doesn't know what has happened, and that is what is making him anxious. So if it is that he doesn't know what has happened, then we need to communicate it to him properly in a way that he understands. Depending on his educational level, depending on his understanding level, we need to communicate to him about his issues, so that if anxiety is because of that, it gets reduced. If it is anxiety in the sense it is fear about the future, about what is going to come, then you can definitely take help from a clinical psychologist if they're available, to treat it and to reduce that anxiety. And many a time sleep disturbances are also caused when a person is facing intense anxiety. So if the sleep disturbance is coming out of anxiety, once the anxiety gets reduced, automatically the sleep quality will also improve. So yes, in this case, I feel for some of the issues, you can definitely intervene on your level by talking to the family, by talking to the patient. And for some of these other issues, you would need to get in touch with other professionals to come in and to help the patient out. Anything else, ma'am, would like to add, or anybody else?
Yeah. So thank you for your contributions. So I would like to know about the daughters and sons, why they are not willing to take care of the patients. Did you talk to them, or is there any issues, any specific issues?
And when they are busy to doing their job, they have long hours of duty.
Okay, so that is why they are not coming to see him.
Yes, ma'am.
Is there any problems between the patient and daughters on any relationship, any special issues, any specific issues?
No, ma'am. Only for their duty they can't come.
Oh, okay. So okay. So because of the heavy duty, they are not able to come to visit him, right?
Yes, ma'am.
Okay. So if they have some sort of this kind of issues there, I have a lot of experience here. If they have some emotional issues like this there, so they may think that okay, they are not willing to see me because of my illness. So I am bed bound. My that children are not willing to take care of that this time. So that kind of thinking, uh, maybe because lack of sleep is one of the cause of lack of sleep. So if they have some issues like this, do one thing, you can listen, you can go there and sit down for few minutes, or for at least 5 to 10 minutes, and listen their worries, and just listen and try to explore their problems. So if they once they explore their emotions with you, sometimes they will during the talk they will cry. So they will somehow they will try to explore their emotions. You can give some time to explore their emotions, then they will get some sort of relief. So after that, if their anxious level is not controlled, you can seek some medical attention, like maybe you can refer the patient to the psychologist. And sometimes if that, you can give some medications too. So if they have some anxious, if they are not able to control their anxious that anxiety, with your non-pharmacological management lead. So then you can refer the patient to the psychiatrist. So that is how we are doing here. Try to explore their problems with our psychosocial workers, and they are also involved in that patient care. And if you are not able to explore properly, or we can not able to treat the patients, we usually refer the patient to the psychologist and get consultation with them. So anybody want to add anything regarding this patient's story? Anything? So financial problems, because he is diabetic for so many years and had been spending too many, yes. So definitely 20 years of history of 20 years of diabetic mellitus, and again 10 years of CV, I think so. So because of that, definitely the financial crisis will be there. So one thing you can do one thing, you can talk to the children about their financial issue crisis, and they will support as much as they can. And also you can refer the patient, you can connect some NGOs nearby. If they are able to support these patients, at least they can able to provide palliative care, home care, and they will give some the treatment as free of cost. So they that way we can able to help this patient. So did he get home care support, Vaishnavi?
No, ma'am.
No, yeah. So then you can connect one NGO if they are doing palliative home care. So you can connect with them so that they can get good support. And also, if there some volunteers are nearby, you can connect that volunteers also within that patient's care. So that time the patient's wives also get some sort of support. So they may feel somebody is behind them to take care of that patients. Any other points you want to discuss? So coming to the physical problems, so this patient is having bed sore stage 4. So we were discussed the last, we already discussed on that bed sore management and all. So malodor, who said malodor? So how will you manage malodor? How will you manage malodor? Yes, metronidazole. So you can apply metronidazole powder. Metronidazole is a drug of choice of controlling anaerobic bacterial infections. You can apply metronidazole, and also you can put 1 or 2 pieces of charcoal in the bedside, and that charcoal will help to absorb the bad smell too. So if this patient is not affordable, better you can take 1 or 2 pieces of charcoal and that place in the side of, maybe you can keep under the bed of the patient, so or keep it in the corner of the room. So that will help to absorb the bad smell. So that way we can able to control malodor. So if the patient is having second stage bed sore there, you can clean with the normal saline. So there is during the second stage there is no slough. So only clean wound is there. You can clean with normal saline. No need of antibiotics. If the wounds have some, if there is any necrotic tissues there, you can do the slough cutting, and then you can apply any antibiotic ointment like metronidazole or whatever you have, you can apply. And also you can advise the patient to prevent further damage of the skin also. You always try to prevent pressure sore. So if the patient is having one sore, you have to prevent another bed sore. So always try to instruct the patient and the family what are the way we can able to prevent pressure sore. Mukta, you want to add anything?
No, ma'am. I think.
Okay.
Yeah.
Yeah. Yes. So we discussed all the points. Definitely, this patient need palliative care. Also, we have to give a proper support to the patient and their family. You have to try to explore their psychosocial issues. If possible, you can try to involve a medical social worker or a psychologist in this patient, in that patient care, and try to explore their problems. If medical social workers and psychologists are not available, at least you go there and sit down and talk to them freely, and that way we can able to explore their emotions. So if you want to give more attention to that patients, try to involve that psychiatrist in that patient care. So, and also you can talk to the children about the patient need, and that patient that request also. Sometimes this patient is also wants to see his children. So that message you have to convey with the children. If they are able to come to see at least once in a week, so the patients feel more happy. Okay. Thank you. Thank you, Mukta, for the wonderful presentation. Vaishnavi, thank you for your case presentation. See you next time. Thank you.
Thank you, Ms. Muktha, for joining us in between your busy schedule. We know that your day might have not ended yet. Thank you for joining us and giving such a detailed insight to the psychosocial aspects in palliative care. And thank you, participants, for joining in. And till the time we see you in the next session with another interesting topic and another eminent faculty. This is Sri Priya along with Ms. Muktha Dhavalikar and Sister Shri Baras signing off from the Tips Eco Hub. See you in the next session. Till then, take care. Bye-bye.